Hello class, Professor Van Dusen here. We are going to talk about depressive disorders in this lecture. Our objectives today are to discuss the role of mood and depression in mental disorders, apply recovery-oriented interventions for a person with major depressive disorder, including those with suicidal behaviors, discuss the need for integrated health care for persons with depression, and develop wellness strategies and goals for a person with depression, major depressive disorder, and suicide. Talking about depressive disorders. So most people have bad days or times when they feel sad and overwhelmed. All of you have days probably when you feel bad or feel overwhelmed. I know I do. Depressed feelings that can interfere with daily activities and relationships though, this is when depression can become a problem, okay? And then we talk about depressive disorders. This mood can impair judgment, contribute to negative views of the world. Depression is the primary symptom of a depressive disorder. A couple of terms to know: mood and affect. So mood is a pervasive and sustained emotion that influences one's perception of the world and how one functions. So if you're happy, everything kind of feels nice and light. But when you're sad, it's like feeling like there's a gray cloud over you all day long and everything just feels kind of crappy and blah. Your affect is an outward emotional expression, and this provides clues to a person's mood. So your affect is how you look when you're having that mood. So if I'm happy, I would have a smile on my face, and that would be my affect, would be I'm smiling. It would be appropriate for being happy. If I was sad, I might be frowning, and that would be appropriate for an appropriate affect for my mood. If I was laughing at something someone told me that was very sad, that would be an inappropriate affect for my mood. Does that make sense? And we'll talk about that more in class and different types of affects. Depression is characterized by sadness, loss of interest or pleasure, feelings of guilt or low self-worth, disturbed sleep or appetite, low energy, poor concentration. This can be overwhelming, and if untreated, has significant negative effects on quality of life. This also increases someone's risk of suicide. Patients with depression experience lower quality of life. They're at greater risk for developing physical health problems, mostly because they're not really getting out of bed, moving around, maybe not taking care of their personal hygiene. This is generally diagnosed in the primary healthcare setting, and sometimes that's simply because they're having these physical problems. They go see their primary healthcare provider, and the primary healthcare provider will say, hey, I think you have depression, and they'll be diagnosed there. This can be characterized by severe and debilitating depressive episodes and associated with high levels of impairment in their occupational, social, and physical functioning. When we talk about how depressive disorders happen across the lifespan, and we talk about children and adolescents, you are less likely to see children be sad and withdrawn. A lot of times they're going to present with anxiety and somatic symptoms. Somatic symptoms are like their stomach aches and headaches, unexplained aches and pains. They're going to have some decreased interaction with their peers. Maybe they'll avoid playing and recreational activities that they enjoy, like maybe if they were in a sport for many years and suddenly decide they don't want to play that sport anymore. They tend to become really irritable instead of sad. They're at a high risk for suicide. A lot of that has to do with their increased impulsivity because of their age. And this is the third leading cause of death among teens. And I want you to kind of think about that. The third leading cause of death among teens, why would that be? Part of that has to do with limited life experience. So their first major breakup, suddenly, these things are happening in their lives, they're getting older, and they have limited life experience to compare it to. So every bad thing that ever happens to them is literally the worst thing that's ever happened to them in their life. And so really it comes down to their resilience and their ability to cope with each of these very difficult things that happen to them in their life as they're growing up. In our older adult population, depressive disorders are often undetected and undertreated. They're commonly associated with chronic illnesses. We have a pretty high suicide rate in those older than 75 years. Um, Treatment for depressive disorders is successful in 60 to 80% of the population, but the response to treatment is slower than that in younger adults. So in younger adults, we can reverse depressive symptoms pretty quickly, but in older adults, not so much. Some signs and symptoms of depression in our older adults are going to be weight loss, memory impairment, insomnia, slower reaction times, difficulty paying attention and focusing. They'll have the somatic symptoms, maybe some change in functioning, and refusal of care. Now, when depression becomes major depressive disorder, and that's what we're going to talk about now, this is a commonly progressive, reoccurrent illness, sometimes referred to as unipolar depression. These episodes tend to occur more frequently, they become more severe, and for longer durations. Sometimes the onset of this occurs in puberty, with the highest onset occurring in persons in their 20s. And we find this with many mental health challenges that onset occurs in late teens to early 20s, and that simply has a lot to do with hormonal changes and suddenly becoming adults, moving out of parents' homes, being responsible financially for their own places, bills, maybe going to college, having, the responsibility of going to school and pressure for grades, and a lot of stress, some experimenting with psychoactive drugs sometimes around this age will also bring on underlying mental health disorders. So we'll see a lot of things happening in late teens to early 20s. So reoccurrence is related to the age of onset. So increased intensity and severity of symptoms and the presence of psychosis or anxiety or personality features. So people who get this early on tend to have more reoccurrences, and the risk for relapse is higher if the initial onset is at a younger age and if they have additional mental health challenges to go with this. There's some diagnostic criteria here. They have to have one or more moods for at least 2 weeks, and 4 of these additional symptoms must be present. So a disruption in sleep, appetite loss, or gaining weight, a decrease in concentration or energy, psychomotor agitation or retardation, excessive guilt or feelings of worthlessness, and having some suicidal ideation. They may feel like they have chronic emptiness, hopelessness, fatigue, no interest in their hobbies anymore, restless, unyielding sadness. And these episodes, they last for more than 6 months at a time. Females have a higher prevalence of experiencing major depressive disorder than males. Ethnicity and culture, how that plays a role. Culture can influence the way depression is experienced and communicated. So we need to assess any culturally distinctive experiences to ascertain any presence of depressive disorder from normal cultural emotional responses. Like if there's a particular culture that has a mourning period after somebody passes away that lasts for an extended period of time, where the person is expected to be outwardly grieving. That would not be a true representation of major depressive disorder, but may be a representation of a cultural experience. Risk factors for major depressive disorder. Prior episodes of depression would certainly put them at risk. A family history of depressive disorders, lack of social support, lack of coping abilities, presence of life and environmental stressors, any substance use, um, and any other comorbidities, especially chronic illnesses. So these chronic illnesses sometimes co-occur with other psychiatric disorders, especially substance related. So they may have depression and alcohol use disorder, or marijuana use, often associated with a variety of chronic medical conditions. Our goals of treatment are really to reduce and control the symptoms and, if possible, eliminate signs and symptoms of the depressive syndrome. We want to improve their occupational and psychosocial function as much as possible. We want to reduce the likelihood of relapse and reoccurrence through recovery-oriented strategies, and these are going to be very patient-specific. Short-term cognitive behavioral therapy. So cognitive behavioral therapy is a type of therapy to change the way we perceive how something happened through our actions, our behaviors, and our thoughts. To take something and perceive it differently will help cope with something that happened, that may be putting this person into a depression or other disorder we'll talk about later. Individual or group therapy, with severe or recurrent major depressive disorder, we certainly need a combination of psychotherapy and pharmacotherapy. That's been found to be superior than any single modality. So having the two together, so a targeted therapy and having some medication together, is really the best we can do for that. If this is not successful, like if they've had the therapy and they've had the medications, and we need to start thinking about more intense therapy, then there's other options available, like ECT at that point. We could also do some light therapy, some repetitive transcranial magnetic stimulation, which is not quite as intense as ECT. And then there's always alternative therapies that could be used together with any of these modalities, and that could be acupuncture, yoga, meditation, guided imagery, massage therapy, music therapy, art therapy. We are going to take a minute now to talk about suicide. Suicidal behaviors. So this is the occurrence or persistent thought patterns and actions that indicate a person is thinking about, planning, or enacting suicide. Some of the things we need to think about with someone's suicidal ideation is it a passive thought or an active thought? If this person is thinking about ending their life, do they have kind of a fleeting thought, like, I wish I could do this, but they don't act on it? That would be passive. Or, I am going to do this, I have a plan, and I'm telling you that I'm going to do this, tomorrow. That's an active suicidal ideation. And we want to identify the frequency, intensity, and lethality of the suicidal ideation someone is having. And this is going to be initially assessed and then reassessed throughout the course of treatment. This will help us determine if we need to change therapies or adjust medication dosages throughout the course of treatment. This requires immediate mental health assessment regarding the depth of their thoughts and intentions. Anytime someone says they have suicidal ideation, they have a suicidal thought, this is our primary assessment. Suicidal ideation always comes first when we do assessments. Risk factors for suicide: lack of availability and inadequacy of social support systems, any history of family violence, including physical or sexual abuse, a past history of suicidal ideation or behaviors, presence of psychosis or substance use or abuse, or a decreased ability to control their suicidal impulses. So our priority nursing care, as I said before, any suicidal thoughts or behaviors are our first priority. Then we want to know, what is their sleep patterns? Have they had a lack of sleep? Sometimes people can go several days when they're really depressed without sleeping, and it can cause psychosis, which can cause these suicidal ideations or impulsivities. We want to know if they've had a loss of appetites and their lack of energy, feelings of hopelessness and self-esteem. Do they have difficulties making decisions? So these are all the kinds of things we're assessing. We want to establish a therapeutic relationship, establishing and maintaining the supportive relationships. And we want to know who is going to be available to them in a time of crisis. If they're an inpatient, then we would be available to them now. But when they discharge home, who's going to be available to them at 3 o'clock in the morning? Because it's not going to be you. It's going to need to be someone else, whether it's a family member, a friend, a support person. That would be important to find out before they're discharged. We want to educate them about their illness and their treatment goals. The more they know, sometimes, the more comfortable they feel with their treatments, and it'll help them make their goals. We want to set realistic goals, okay? They can be short term, maybe this week, maybe within a couple of days, even if they're inpatient, it could be by the hour. But we don't want to make really bold goals like next year you're going to buy a house, if today they don't have a job. We want to make sure that we stay realistic in our goal setting. We need to support the individual's strengths in their treatment choices. Okay, and when I talk about strengths in mental health, I don't mean how much they can bench press in the gym. I mean, what are they already doing well? Like, what are they strong at? What are they good at? And then we want to make sure that we encourage them to keep doing that if it's working well and if it's something that's healthy and okay for them to do. And we want to avoid cheerleading. So we don't want to go over the top and saying, yes, 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 you should, that's great that you do that, but we want to make sure we're supporting them. Making sure you earn your patient's trust. And that can be something as simple as asking them if they want a glass of water, going and getting it, and actually bringing it back to them. All those little steps of remembering things that you've said you were going to do and following through will earn their trust. Sometimes using their first name when you talk to them so that they know you remember them also helps build trust. Maintaining eye contact if it's culturally appropriate will also help with earning patients' trust. Some physical care things we can do. We want to make sure we reestablish a normal sleep pattern and healthy nutrition. Um, Encourage some deep breathing exercises. We want to get them doing some activity and exercise, especially if they've been in bed for long periods of time, even if they're not sleeping, but they're just being immobile. We want to get them up and moving. And then certainly we're going to consider pharmacologic interventions. And that's going to be like our SSRIs, SNRIs, MAOIs. So these are going to be our antidepressant therapies. Our major goals are going to be to help this patient be as independent as possible, right? We want to achieve stability, remission, and recovery from any major depression. This can be a lifelong struggle. So ongoing evaluation of their symptoms, their functioning, and their quality of life should be carefully documented in order to monitor the outcomes of future treatments. So knowing where they are, making sure if we need to adjust their therapy, maybe put them in a different type of therapy, adjust their medication dose, or maybe try a different medication therapy, all needs to be assessed and reassessed. Any psychosocial interventions, whether they're cognitive, behavioral, group therapy, psychoeducation, some milieu therapy if they're inpatient, family interventions, bringing in family members and seeing if we can reestablish support systems within their family network, and then setting them up with support groups or encouraging them to go to support groups. And that's whether it's a support group that's local that has like actual people that get together, or if it's an online support group where we have Zoom as an option where they could join, or even a social media outlet. Facebook has many support groups. You could type just about anything into Facebook and find a support group for it. When we talk about overall mental health assessments, if the patient is not suicidal and has not stated a suicidal ideation, their physical health gets assessed before their mental health. And sometimes that's simply because they might have an injury or something going on that's causing them pain, or something physically wrong with them that's causing their depression, causing their anxiety, causing their mental health issue that we might be able to fix before jumping into straight mental health interventions. So we always do a physical health assessment first and get a baseline. Unless they're suicidal. If they express suicidal ideation, that jumps to the top of our prioritization, and we'll do an assessment for that before we do a physical assessment because that is priority. But in general, if they are not suicidal, we do a physical health assessment first. That is a review of systems, a thorough history of their medical problems, any past surgeries, medical hospitalizations, head injuries, OBGYN history, a physical examination with a baseline of their vital signs, a baseline of lab tests, and an ECG. Those three things are important if we decide to start someone on new um, psychiatric medications. We want to know if they've had any appetite or weight changes, any sleep disturbances, if they're tired, if they have decreased energy or any fatigue. We want to know about their medications that they take. What are their prescribed medications? What do they take over the counter? Are they taking any herbal supplements? Because remember, sometimes these can interact with each other. What is the frequency and the dosage, and when was their last dose? Any substance use assessment. A lot of people who have depression or other mental health challenges tend to have a substance use disorder. Not all of them, but many of them. So we want to assess for use of alcohol, marijuana, or other mood altering medications. And then a psychosocial assessment. How is their mental status? How are their coping skills? How do they already cope with whatever is bringing them to us? What is their psychiatric family history? Does anyone else in their family have psychiatric issues? And sometimes first degree relatives, things can run in families. What is the quality of the support system that they have now, if they have one at all? And what kind of education do they have about their current disease process or illness? And that is all I have for you for our depressive disorders lecture.